Hello, dear learners and my dear students. Today I am going to discuss an important topic about the disorders of white blood cells. As we all know that there are three important cells which are synthesized by the bone marrow, and it is an important part of the circulatory system, and also it plays an important role in the body's functions, whether it is related to proper functioning of all the organs or defense or other mechanism which is important for smooth functioning of the body parts. Now here, three important cells which are produced in the blood are red blood cells, white blood cells, and platelets. Now, what happens if its synthesis is either below or above the normal level? So we all know that red blood cells, if it decreases, it important cause is the anemic condition, that is the loss of blood, and anemia may be of different types. Either it may be acquired or hereditary, like sickle cell thalassemia, whereas white blood cells play an important role in the defense mechanism, and it constitutes our immune system, our immune system. Now, we know that platelets and red blood cells are have only a single type of cells. They are only single type of cells, and red blood cells reduction or increase may cause anemia or polycythemia, whereas platelets are involved in the clotting mechanism of the blood body, and its increase or decrease may cause disorders associated with the bleeding disorders. Now, white blood cells constitute of two types, that is the agranulocyte and granulocyte. Granulocyte is further classified into three types, that is the neutrophils, basophils, and eosinophils, and agranulocytes, two important cells, that is the lymphocytes and monocytes. Now here, as the bone marrow, we know that it is of two origin, that is the bone marrow is of lymphoid cells, constitutes of lymphoid cells and myeloid cells. So usually what happens that red blood cells or platelets originate from the single lineage of the cells. Means that only a particular type of blast cells or precursor cells are involved in their synthesis, whereas since there are different types of white blood cells, and therefore also they originate both from the myeloid and lymphoid cells of the bone marrow. So their precursor cells also vary, and each white blood cells have its own distinct functions. For example, neutrophils are involved in developing the immune system against some infections, whereas we know that eosinophils mostly responsible in the case of parasitic infections, developing defense, then immune system immunity, whereas basophils are involved in allergic response. So they have a variety of functions, different functions, and so their lineage cells or their originating cells also vary there. Now here the things becomes complex because each deficiency or increase or each abnormality in each type of white blood cells can cause different type of disorders in our body. Now here it may be the disorder may be both type, that may be either quantitative or qualitative disorders, means that either their numbers may increase or decrease, whereas in qualitative means the type of white blood cells which is being synthesized. Either it is immature cells are being released, or immature or any precursor cells are more prominent. So these are the different type of disorders. In addition to that, there are certain viral infections and also which are also responsible for the malfunctioning of these white blood cells. So we will see in detail today in this lecture. We will see about, mostly we will focus on the quantitative disorders, means their how their number may increase or decrease in the body. Now let's start today's lecture. So first of all, we will see that these are some of the important cells in our body. Here you can see that neutrophils here. The see neutrophils. Now here neutrophils, eosinophils, and basophils are the granulocytes. Means they have in their cytoplasm some granules, and its importance of the granules is that they act as a they release some chemical substances or cytokines which acts as a chemical messengers for other even their activation of their own cells or other cells of the body. So here you can see here that neutrophils are the major white blood cells which is present in the body, and it comprises 60 to 70% of the total white blood cells in of the total white blood cells in the blood. And usually you will observe that these granulocytes have segmented lobes of nuclear lobes. Here in the neutrophils, there are 3 to 5 lobes are present in the cells nucleus part, whereas the cytoplasm demonstrates fine purple granules which contains various enzymes which kill and digest the organism. Neutrophils stain positive for myeloperoxidase, alkaline phosphatase, and chloroacetate esterase. Their main function is defense against infections. Now, normal neutrophil number is attained by the age of 4 to 8 years. Earlier during the infancy period, usually lymphocytes count is more, but as the age of the person increases, slowly neutrophils predominate. Now, one is the hypersegmentation, means that hypersegmentation of neutrophils. This contains 6 or greater than 6 lobes of the nuclei are observed in microcytic anemia and myelodysplastic syndromes. Now, if the lobes of the neutrophils exceeds, it may also indicate some other disorders. Now, one thing we have to notice that all these blood cells, either it is red blood cells, white blood cells, or platelets, are interrelated to each other. Means one increase can affect the function of other cells. One increase or decrease can affect the function of other cells also. It is not necessary that if there is an alteration in the white blood cells, it will not impact the red blood cells or platelets. Similarly, if red blood cells are if there is a disorder in the red blood cells, so it may also impact the white blood cells. Similarly, here the same thing, that if hypersegmentation of neutrophils takes place, then it may indicate that microcytic anemia or myelodysplastic syndrome. Next is you can see here the eosinophil parts. So eosinophils comprises 1 to 4% of the white blood cells, and the nuclei are bilobed. You can see here that there are 2 lobes are present there, and it looks like a spectacle. So the glass of the spectacle, the design of the spectacle for if we observe it under the microscopic examination, we can easily identify it. Now, with a specific orange or red colored pores granules, regular granules, peripheral part of the granules is positive for peroxidase and Sudan black B. Eosinophils play a major role in allergic inflammations. Eosinophils contains 2 types of granules. One is the primary granules, which appears at pro-myelocytic stage and contain eosinophil peroxidase, which is different from myeloperoxidase and charcot-laden crystals. Okay, and secondary granules are developed at myelocyte stage and contains eosinophil peroxidase and major basic protein. So basically, two promyelocyte and myelocytes are the precursor progenitor cells during the stage of development of eosinophils. Now, next is the important cell is the basophils. Now, here you can see here the basophils comprises approximately 0.3 to 1% of the circulating white cells. So these are very less in numbers, and even in the peripheral blood smear, it is rare to see. Sometimes it is very difficult to observe these cells. Now they have multi-lobe nuclei which are partly to completely covered by dark staining basophilic granules. Now here you can see that the important characteristics is that here all granules are covering the nuclear parts. So it is covered throughout, the nucleus is covered throughout by the basophilic granules, which are positive for peroxidase. Basophils, along with the mast cells, have a major role in hypersensitivity reaction type 1. These cells release histamines and other cytokines. Their release occurs following the activation of mast cells and basophils following antigen attachment to cytotropic IgE in various allergic disease states. Next is the monocytes. You can see here there are two classes of phagocytic cells. One is the neutrophils and the other is the monocytes or macrophages. The monocytes are circulating in the blood while macrophages are localized in the tissues. Now, the important difference is that each macrophages are known by distinct name. For example, in the liver, if they are a site, they are called as the Kupffer cells. So, for different tissues, their name varies. So, here monocytes comprises about 4 to 5% of white cells in circulation. They have a reniform or lobated round to oval nucleus with glassy chromatin. So chromatin is like glass-like, and you can say here that they are slightly concave shaped. This nucleus, you can say, curved, or we can say that there is the nucleus here is the entire. You can see here that is in the curve-like shaped. Okay. So here monocytes are circulating in the blood 4 to 5%, and they have a reniform or lobated round to oval nucleus with glassy chromatin. The cytoplasm is abundant and is pale grayish blue on Giemsa staining. Monocytes stain positive for non-specific esterase. Then half-life of monocytes is about 18 hours. And their main function is phagocytosis. Monocytes migrate into tissues and mature into macrophages. Next, the important white blood cell is the lymphocytes. So in the lymphocytes, you can say that it is a assessment of the lymphoid system. They provide an assessment of the lymphoid system because all other cells are from the myeloid origin, whereas these lymphocytes lymphoid origin. They are from the lymphoid origin, so they can easily provide that whether the lymphoid cells are working properly or not. Now they comprise 25 to 40% of the white cells in the peripheral blood, and majority are small lymphocytes and few are large lymphocytes. Again, it is further classified into two types. That is the large lymphocytes and small lymphocytes. Majorly, they are mostly they are constituted by small lymphocytes. Now, what is the difference between the small lymphocytes and large lymphocytes? So, a small lymphocyte size is approximately that of a mature red cells. That is 8 microns. We can say that the size of a mature red cells is approximately 8 microns. And with a thin rim of pale blue cytoplasm, nuclear chromatin is markedly condensed. Now, here, most of the cytoplasm is covered with the nuclear part, and very few part of the cytoplasm is visible. Mostly it is the nuclear part. Next is the large lymphocytes. They are 14 to 16 microns. Obviously, they are bigger than the large small lymphocytes, and they are 14 to 16 microns in size with central or eccentric nucleus. So they are going mostly the central nucleus is confined to the central part, and with clear pale blue cytoplasm contains nuclear chromatin without any nucleoli. Now coming to the, you can see here that what is the normal differential counts. So here you can easily understand the how the different leukocytes constitute and what is their count in percentage and absolute count. So neutrophils 2.5 to 7.5 into 10 to the power 9 liter, 1.5 to 3.5 into 10 to the power 9 per liter of lymphocytes, monocytes 0.2 to 0.8, then eosinophils 0.04 to zero point 0.4, and basophils 0.01 to zero point 0.1. And here also the respective percentage of their parts. Now coming to the view, obviously we all know that we are discussing about the now what happens if the count of suddenly of these white blood cells increases from the normal level or decreases. So we will see one by one. First, we will discuss about if there is an increase. So the conditions where we all of you know that the normal WBC count is 4,500 to 11,000. So if the WBC count is greater than 11,000 per microliter in adults, that is called as the leukocytosis. And if it increases to 100,000, so it will that will called as the hyperleukocytosis. So the term for overall WBC count is called as the term used medical term is the leukocytosis, and more than 11,000 then it is called as the 100 till 100,000, that is called as the hyperleukocytosis. Now next is the what happens if there is a individually increase in the different type of cells. Now here one thing important thing that usually as we know that neutrophil is the main constituent, so mostly the leukocytosis occurs with an increase in the neutrophil, absolute neutrophil count. But it is not necessary that only neutrophil. In some cases other cells like basophils or monocytes, eosinophils, lymphocytes may also increase, but in the most cases, neutrophil count is seen as raised. So first we will discuss that, and the condition where the neutrophil count increases is called as the neutrophilia. So what is neutrophilia? So we know already you have seen the percentage that it is 45 or 40 to 75% of the total white blood cell count constitutes of the neutrophil. Now, obviously, if the neutrophil count increases more than 75%, that will the condition will be called as neutrophilia. Now here there are more than 75% neutrophils in peripheral blood. Usually neutrophilia is accompanied by leukocytosis greater than 20 into 10 to the power 9 per liter. So if the it is increase is 20 into 10 to the power 9 per liter, and neutrophils in bacterial infections demonstrate toxic granules. So one of the characteristic feature is the toxic granulations. Tohle bodies 1 to 4 microns in size and round oval structures in the peripheral part of the cytoplasm, and observed conditions like scarlet fever, then septicemia, pneumonia, and burns. Neutrophilia occurs because of increased production of neutrophils in infections and inflammations, increased marrow release as in steroid therapy, and defective marginations as in stress and in exercise. Now here one important term comes is the leukomoid reaction. But before discussing about the leukomoid reactions and the left shift, we will see what are the causes of neutrophils. So first of all, there is infections, obviously. So different type of infections like bacterial, acute bacterial infections like pneumonia, pyogenic meningitis, cellulitis, infected burns, and diphtheria are the common acute bacterial infections. Then coming to acute inflammatory disease like acute rheumatic fever or acute appendicitis. Then acute stress states like post-surgery, post-hemorrhage, myocardial infarction, then myeloproliferative disease disorders like chronic myeloid leukemia, polycythemia vera. Miscellaneous we can include steroid therapy, renal failure, gout, rheumatoid arthritis, and GCSF theory, that is granulocyte colony stimulating factor therapy. Okay, so GCSF therapy. So these are some of the important causes. Now coming to the topic, that is the leukemoid reactions and left shift. So what is leukemoid reaction? The term, we all know that if there is a malignant cells due to white blood cell disorder, that is called as the leukemia. And if the conditions, if it's not a leukemia, but it shows symptoms of leukemia, that is called as the leukemoid reaction. So it is very important to distinguish between leukemia and leukemoid reaction. So what is leukemoid reaction? The term leukemoid reaction is used to indicate a condition where the total leukocyte count exceeds 50 into 10 to the power 9 per liter, along with the numerous band forms, metamyelocytes, myelocytes, and few promyelocytes. Rarely, few blast cells may be seen. The commonest cause is infection, sepsis, which may result in toxic granules and Dole bodies. Now, next is the left shift. Left shift is an increase greater than 20% in the number of band cells. That is also called as the bandemia in relation to neutrophils is noted by left shift. When the left shift occurs, immature cells like metamyelocytes, myelocytes, and promyelocytes are released into peripheral blood. Presence of band cells is a clue to infections. So these are the two important, that is the leukemoid reactions and left shift of neutrophils. Next important term. So this is we discussed about the neutrophilia. Next is the lymphocytosis. So in lymphocytosis, we know that the percentage is 20 to 40%. It constitutes 20 to 40% of the lymphocytosis. So here, what happens that in lymphocytes, when lymphocytes are more than 45% in the peripheral blood, in adults, lymphocytes are greater than 4 into 10 to the power 9 per liter. In children, it is greater than 7 into 10 to the power 9 per liter. And in infants, lymphocytes should be greater than 9 into 10 to the power 9 per liter to indicate the condition of lymphocytosis. Reactive lymphocytosis. Reactive lymphocytosis indicates it is associated with acute viral illnesses such as infectious mononucleosis, dengue fever, and whooping cough. In viral-induced lymphocytosis, typically a mixed population of small lymphocytes, plasmacytoid lymphocytes, and larger lymphocytes is seen. Common causes of lymphocytosis is as follows. Chronic infections. In case of chronic infections like tuberculosis, brucellosis, syphilis, then hematological malignancies like chronic lymphocytic leukemia, non-Hodgkin's lymphoma with spillover, adult T-cell lymphoma, leukemia, hairy cell leukemia, pro-lymphocytic leukemia. Then coming to the acute infections, infectious mononucleosis, infectious monocytosis, mumps, measles, chickenpox, toxoplasmosis, and viral infections. Next comes the eosinophilia. So eosinophilia, we know that it constitutes about the eosinophils 2 to 6% of the total white blood cells. And if we discuss in absolute count, then it is 0.04 to 0.4 into 10 to the power 9. So if it is 0.6 into 10, more than 0.6 into 10 to the power 9 per liter, it is denoted as eosinophilia. Eosinophilia increases mainly in allergic, parasitic, and skin disorders. Now, what are the causes of eosinophilia. So there are two types. One is the primary eosinophilia and other is the secondary eosinophilia. So what are the primary eosinophilia? It may be again primary chronic and myeloid leukemia, in the case of primary eosinophilia, then chronic eosinophilic leukemia, then mastocytosis, AML, M4, EO, that is the acute myeloid leukemia, M4 stage, as per FAB classification, idiopathic chronic eosinophilic pneumonia, and acute eosinophilic pneumonia with respiratory failure. Coming to the allergic states is in the case of primary eosinophilia is the asthma, urticaria, hay fever, and rhinitis. In parasitic diseases, it is roundworm infestations, hookworm infestations, filariasis, then trichinosis, skin diseases, eczema, psoriasis, pemphigus, bullous pemphigoid, dermatitis, herpetiformis, and miscellaneous, you can say that tropical eosinophilia, pulmonary eosinophilia, hypereosinophilic syndrome, eosinophilic granuloma, Hodgkin's lymphoma, and Addison's diseases. So these are some of the important causes of eosinophilia. In addition, primary, it may be primary or secondary, as I have already discussed. So here, primary eosinophilia may be clonal or idiopathic. Clonal eosinophilia is seen in myeloproliferative neoplasms or acute leukemia, genetic mutations involving PDGFRA, PDFRB, and FGFR1. FGFR1. See, once again, I repeat, PDGFRA, PDFRB, and FGFR1 have been linked to clonal eosinophilia. Clonal eosinophilia is also associated with CML, chronic myeloid leukemia, then chronic eosinophilic leukemia, mastocytosis, and acute myeloid with INV16. So that is these are some of the important parts. The secondary eosinophilia include tissue invasive parasitosis. So this is the two types, primary and secondary eosinophilia. Next, coming to the monocytosis. So what are the causes of monocytosis? So monocytosis is caused by the increase in, obviously there is an increase in the count. Already we know that monocytes have 0.2 to 0.8 into 10 to the power 9 per liter, whereas percentage is 2 to 10%. Now here, increased chronic infections, some parasitic disease and chronic inflammatory disorders. Absolute monocytosis defined as monocytes greater than 1 into 9, 1 into increase greater than 1 into 10 to the power 9 per liter. And in adults, and greater than 1.2 into 10 to the power 9 per liter units, normal monocytes demonstrate positivity with non-specific esterase staining. Monocytes are positive with CD11B, CD14, CD64, CD163, and CD68. Now, what are the causes? Infections include tuberculosis, malaria, Kala-Azar, trypanosomiasis, bacterial endocarditis, syphilis, brucellosis. Hematological malignancies include AML, M4, and M5, chronic myelomonocytic leukemia, Hodgkin's disease, and myelodysplastic syndrome. That is the MDS. Next is the inflammatory diseases, ulcerative colitis, Crohn's diseases, systemic lupus, erythematosus, sarcoidosis, rheumatoid arthritis. So these are some of the important causes of monocytosis. Now coming to the basophils. So basophils are increased in few conditions. That is a chronic myeloid leukemia and polycythemia vera, ulcerative colitis, myxoderma, mastocytosis, acute basophilic leukemia, Hodgkin's lymphoma, and tuberculosis. Now these are some of the conditions which we have discussed when the individual white blood cells count increases. Now, what will happen if their count decreases from their normal level? So we will discuss some of the important conditions. Now here, if the count of neutrophils, as we saw in previous slides, that if it is increases, the term conditions we use is the neutrophilia, and overall WBC count including leukocytosis. Now, if the neutrophil count decreases, then that condition is called as the neutropenia. Or other term we can use is the agranulocytosis. Now, what is the agranulocytosis or neutropenia? So we will see here. So neutropenia occurs when when neutrophil count is decreases to or less than 2.5 into 10 to the power 9 per liter in children and less than 1.5 into 10 to the power 9 per liter in adults. Patients become prone to infections as neutrophils decrease to less than 0.5 into 10 to the power 9 per liter. Neutropenia is caused by suppression of myelopoiesis, means myeloid bone marrow, means synthesis of myeloid cells. There is suppression, then peripheral destruction of neutrophils or peripheral pooling. Now, what are the important features? Before that, the suppression may be selective or generalized, involving erythroid or megakaryocytic cell lines as well. For example, is the aplastic anemia. Peripheral destruction of neutrophils is due to anti-neutrophil antibodies, autoimmune disease, or due to certain drugs like aminopyrine or phenylbutazone acting as aptans. Peripheral pooling observed in hemodialysis and cardiopulmonary bypass. So clinical features are some of the important are sore throat, boils, skin infections, paronychia, ulcers in the mouth, periodontitis, abscesses, poor wound healing. Now in the peripheral blood, so before going to the diagnostic part, we will see what are the important causes of neutropenia. So antibacterial drugs are some of chloramphenicol, cotrimazole, penicillin, doxycycline, ciprofloxacin, nitrofurantoin, cephalosporins, gentamicin. So we already know, or in general also we know that antibiotics have some side effects. So you can see that these drugs can substantially decrease the neutrophils. Now coming to the anti-inflammatory drugs, phenylbutazone, aminopyrine, and ibuprofen, anti-thyroid drugs like thiouracil, carbimazole, anticonvulsants like valproic acid, phenytoin, and trimethadione. Next is the autoimmune diseases like systemic lupus erythematosus, idiopathic syndrome, then Felty syndrome, infections, enteric fever, gram-negative bacterial septicemia, tuberculosis, HIV diseases, in viral parvovirus B19 infection, HIV infections, hepatitis B infections, Epstein-Barr virus infections, protozoal, malarial and calazar, and miscellaneous chronic autoimmune neutropenia, cyclic neutropenia, aplastic anemia, myelodysplastic syndrome, hypersplenism, megaloblastic anemia, and X-ray irradiation. So these are some of the important causes of causing neutropenia. Now, what are some of the important blood examination in the case of neutropenia? So, when we observe peripheral blood, some of the important conditions we will see here. So, complete blood examination is required to rule out various causes of pancytopenia. So, in this case, hemoglobin will be normal. Total count, obviously, if the neutrophil decreases, total count will also decrease. Then in the differential leukocytes, you will observe neutropenia with neutrophils being from 0 to 20%. That is very from 40, usually it constitutes 40 to 75%. So there is a very very important diagnostic features that only 20 from 0 to 20% is only observed in the differential leukocyte count. Now, absolutely coming to the absolute neutrophil count. So here, when no neutrophils are seen or very less, so we proceed for absolute neutrophil count. Here, less than 0.5 into 10 to the power 9 per liter is a severe form, and between 0.5 to 1.5 into 10 to the power 9 per liter is moderately severe neutropenia. So next is the bone marrow examination. So in bone marrow, is essential to rule out other causes of neutropenia like subleukemic, aleukemic leukemia, megaloblastic anemia, and aplastic anemia. Here, if you see here, if bone marrow examination, so bone marrow is essential to rule out other causes of neutropenia. Cellularity is normal, erythropoiesis is normoblastic, myelopoiesis is where through which these neutrophils are synthesized. A number of cases manifest maturation, arrest, or at pro-myelocyte or myelocyte stage. In some of the cases,
there is depletion of the cells of myeloid series. In few cases, promyelocytes and myelocytes demonstrate cytoplasmic vacuolation. Then megakaryopoiesis, that is a formation of platelets normal. In severe infections and septicemia, hypoplasia of myelopoiesis may result in neutropenia. Basically, mostly in the bone marrow examination, we observe the condition of myelopoiesis. That is the myeloid precursors of myeloid cells are being synthesized properly or not. And obviously, neutrophil count is low. There is some defect in the process of myelopoiesis. Other conditions mostly remain normal. Then coming to the next case, that is the lymphocytopenia. So in the lymphocytopenia, there is an absolute reduction in lymphocyte is less than 1 into 10 to the power per 9 per liter in adults and less than 2 into 10 to the power 9 per liter in children, observed in peripheral blood smears. Then this is observed following steroid therapy, mostly steroid therapy, then anti-cancer drugs, radiation-induced, and HIV radiation-induced and HIV infections. Some of the important causes are some of the drugs causing lymphocytic destructions are corticosteroid, cytotoxic drugs, anti-thymocyte globulin, and in miscellaneous you can see miliary tuberculosis, then AIDS, advanced malignancies, ataxia, telangiectasia, rheumatoid arthritis, systemic lupus erythematosus, radiation therapy, sarcoidosis, and myasthenia gravis. So these are some of the important reasons of causing lymphocytopenia. Then comes the monocytopenia. In monocytopenia, conditions is mostly caused in aplastic anemia, then steroid therapy, hairy cell leukemia, and acute myeloid leukemia. So these are some of the important conditions where there is a decrease in the white blood cells count. These are some of the important parts of the quantitative disorders of leukocytes. Now coming to the qualitative disorders, we see here that these are the rare familial disorders which manifest morphological changes in leukocytes. And so we say it is a quantitative change, and I picked up while examining the peripheral smear and bone marrow. Some of these are Pelger-Wet anomaly, Elder-Riley anomaly, May-Hagley anomaly, Chediac-Agassiz anomaly, and chronic granulomatous disease of childhood. So qualitative disorders we will discuss in our next lecture. I hope so I conclude today's lecture. I hope you have gained some knowledge from my lecture. If you really if this lecture really helped you, please do like and subscribe to my channel, which will keep me motivated to bring you informative video on the subject. Thank you all.